So today I'm going to talk about implementing change, the different perspectives. The idea is having the outline of the presentation today would be using evidence to promote change. I will use 3 examples: companionship at birth, time to cord clamping, and long-term effects of model delivery, and afterwards implementing change, the different perspectives. And we have this group exercise about change. And I will resume a concept that I talked very briefly in the first day about localized knowledge. That is the idea that different social actors have different perspectives from knowledge. They understand and they conceptualize the same situation differently, and how conflicts of interest have to do with this. So the first thing is companionship at birth, and I always already mentioned this to you, but I will briefly repeat this story because I think it's a very beautiful story. That in Canada, in the 80s, there was this research about what women liked or didn't like in their experience in childbirth. So they, in average, met 16 different people during childbirth, but were most of the time alone. And the worst thing of all for them was loneliness during childbirth. So they wanted companionship, they want people to be with them, etc. And when they presented this research, people said, oh, this is very interesting, but this is cosmetic things, it's not science. So a researcher there in her group, Ellen Hodnett, she decided to use the methodology that they use for drugs, randomized controlled trial, and she randomized women for companionship and not companionship. And the result was wonderful. Of course, everybody wanted companionship. All the outcomes for mother and baby were better with companionship. You know, it was amazing. And by the same time, they also started to think about, was very interesting works, qualitative work, anthropological work about the importance of having birthing companions. And also something that is called doulas. Do you have doulas? Have you heard of doulas here? Doulas are birth companions, professional birth companions. It's someone who meets the woman during childbirth. She takes care of perinatal education, antenatal education. What is different from antenatal care? Antenatal care is a broad concept, but generally the woman waits for several hours to see the doctor. Then the doctor hardly looks at her eyes, but measure. Do some physical examination, etc., isn't it? And the doula is someone who listens to the woman, her concerns, and provide education about childbirth and so on, depending on the country. You know, you have this or you do not. And she goes with the woman and helps her during her childbirth and postpartum and breastfeeding. It's a different format depending on the setting. In Brazil, we have these different formats. But also can be, you know, the husband, the partner, the mother. You know, we did this survey in Brazil called Birth in Brazil. And we mapped who was the companion, what was the reason why people didn't have companion, what were the obstacles of having companions. So this is, I think that we have published this in English. Yes, we did. I will show you our paper about companionship and what were the factors associating of not having a companionship. But in Brazil, we have a law. In the state of Sao Paulo, we have a law since 1999. And there's a national law since 2005 that every woman has a right of companionship of her choice. You know, she's the one who chooses who she wants. Since the first law, it was based on these systematic reviews, you know. So it's a very much evidence-based, Cochrane-inspired law. So I very much, we can find this in the open access of Cochrane. This is the last version, the 2013 version of the systematic review called Continuous Support for Women During Childbirth. There's a link here for the PDF. It's a huge review, you know. It has the history of the review, the history of companionship, the explanatory models of why it works so much, so well. So that's all the theories about reducing stress, the theory about moving around, the theory why it has this kind of magical effects. It has, you know, I think that 100 pages of meta-analysis graphs about the subgroup analysis. It says subgroup analysis for anything. Subgroup analysis for middle-income countries, low-income countries, settings that have epidural, settings that don't have epidurals, primipara, multiparas, all kinds of subgroup analysis. It's extremely helpful. I teach evidence-based public health, you know, and one of the things are meta-analysis. So I don't use any meta-analysis of drug. I use this one because this is a masterpiece. It's very good for you to learn about what is a clinical trial, what is a systematic review, and how to read a meta-analysis graph. You know, it's very, very good. So, these reviews, they have a regular summary and they have a plain language summary that I will read for you here, because I'm not sure you can read this. This says, historically, women have been attended and supported by other women during labor and birth. What is the aim of the plain language summary? Is that a lay woman will read this, okay? And she will, that's including some methodological issues. However, in many countries, as more women are giving birth in hospital rather than at home, continuous support during labor has become the exception rather than the norm. This may contribute to dehumanization of women's birth experiences. Modern obstetric care frequently subjects women to institutional routines, which may have a adverse effect on the progress of labor. Supportive care during labor may involve emotional support, comfort measures, information, and advocacy. These may enhance physiological labor processes, as well as women's feeling of control and competence, and thus reduce the need for obstetric intervention. In this review of studies, including 23 trials from 16 countries involving more than 15,000 women in a wide range of settings and circumstances. The continuous support was provided either by hospital staff, such as nurses and midwives, women who are not hospital employees and had no personal relationship to the laboring women, such as doulas or women who provided with a modest amount of guidance, and by companions of the woman's choice from her social network, such as her husband, partner, mother, or friend. So women who received continuous labor support were more likely to give birth spontaneously, give birth by neither cesarean nor vacuum nor forceps. In addition, women were less likely to use pain medication, were more likely to be satisfied, and had slightly shorter labors. Their baby were less likely to have low 5 minutes APGAR scores. No adverse effects were identified. We conclude that all women should have continuous support during labor, and so on. The rest is about who could. So this is very much used as a form of advocacy, you know, with services, because this, let's say, gold standard of healthcare. This is the first issue that we are going to prepare our scenes, our role plays, okay? What happens, and you are familiar with hospital settings, right? Okay? And you are aware of the kind of difficulties people may find about having companions of their choice or whatever. So the second one is the timing of cord clamping. And so there is a campaign called Wait for White, you know? It's very interesting because in our research in Sao Paulo, in the hospital that we are working, it's a very poor, it's a hospital with a history of attending very poor mother, very destitute mother, single mothers, and so on, that wants to change its image, for a place that people would. And they have a partnership with the fanciest hospital in Sao Paulo. And the fanciest hospital in Sao Paulo has a stem cell, unit. And people receive a folder saying, oh, this blood, this stem cell that would go to the trash is now used to save lives. And they get this 1/3 of the blood of the babies, for every single baby that goes there. And that's amazing, because this is the reason why we discuss a situation that we are facing there in Brazil. But most of them is that one of the difficulties of cord clamping is that when you have more than the half of the birth by C-section, or in the private sector that you have 90% of C-section, the baby, when it's taken from the uterus, the cord is cut immediately, and the neonatologist is there waiting, So people do not have the culture of waiting for 4 minutes, 5 minutes there, for, the cord stop with pulsating. So in a physiological birth, it's much easier because nobody's concerned about, what's going to happen, So I strongly suggest a reading of this material by WHO, many other institutions, about delayed cord clamping as the main strategy to reduce infant anemia,
Very, very high rates of childhood anemia.
So this is the so-called quaternary prevention, You don't need to produce the anemia for them to treat the anemia, right? I've shown you. I even thought of having, let's try YouTube again. I'm going to show you the trailer of this video. I use it very much in my classes for the students. Why I'm showing this to you? Because I think this is the best argument for parents or mothers, because we are taught that it's safer for the baby, it's better for the baby to be born by C-section, by elective C-section. It's more, we learn at medical school in Brazil that the doctors used to say, I have already regretted, in Brazil people say, doing a birth, making a birth, as if making a vaginal birth, I have regretted, but never I regretted a C-section. So, this climate of fear that women are put, about vaginal childbirth. And I'm not saying at all that vaginal birth cannot be very scary, as we have been talking about these days. But the idea is the concept of safety that we had related to C-section, it's not what seems to be in terms of the best recent evidence. And as we know, this evidence sometimes takes a lot of time to be mainstream evidence or to be incorporated. So it's our responsibility to spread the word, Otherwise, this is a very powerful argument. We are using very much this kind of argument for mothers, and this is something that people are really concerned about. So it says, we'll show why we must change medical education, antenatal education, the way we view birth. So very briefly, what is the change in our understanding? First of all, we understood gene as blueprint, as if we have machinery and everything was defined there. I think that this is the vision pre the human genome project, that everybody put a lot of money, a lot of effort, and everybody was convinced that would understand everything about health and disease afterwards. And then when the book was opened, people could not read it, or it did not correspond exactly what people were waiting. Yeah? And now we have the the idea of genome as a mixing board that is turned on and off, by different situations. And one of most important of them, the whole perinatal period is very important. Pregnancy is very important. Childbirth is very decisive, and the first 1,000 days, breastfeeding, etc. And there's a very strong relationship. There is this paper that's here. It is very interesting because it describes the physiology of the development of the immune system and the relationship of the formation of the microbiome and epigenetic changes. So those who are more related to medical science or nursing, etc., this is a very good reading. How disturbing the bacterial colonization and this altered epigenetic regulation of gene expression because of labor can lead to this failed maladaptive immune activation, related also to what I said on Friday. Remember this idea of distress, what is toxic stress? It activates and deactivates genes. And our stress, the absence of stress, also does not activate the genes that were supposed to be activated, because this is the reason why we need this eustress, the physiological stress. Thank you.